So without further ado, let's get on to the first session. And I'd like to invite Dr. Carolina Olano to join me as co-chair for the first session. Carolina is a professor in the Department of Gastroenterology in the National University of Uruguay in Montevideo, Uruguay, and has been, as you've already heard, a member of the planning committee for this particular meeting. So as the theme of this first session is epidemiology and sociocultural issues, we will start with a state-of-the-art lecture which will really set the tone for this discussion. It will be followed then by 4 presentations from different parts of the world which will discuss their experiences with irritable bowel syndrome. And then, as Amy mentioned, we will have a prolonged discussion session, and we would like to hold all questions until that session at the end, when we will bring, so I'd ask each speaker to come up, give their presentation, then sit down, and then come up at the end of the session and join us for the panel discussion. So without further ado, I'd like to introduce Dr. Byron Good, who's going to be our theme-setting speaker, and he's Professor of Medical Anthropology and former chair, as well as Director of Programs in Global Mental Health in the Department of Global Health and Social Medicine at Harvard Medical School. He is former editor-in-chief of Culture, Medicine and Psychiatry, and he's had a long interest in how culture influences illness experience and the expression of symptoms, with a particular focus on psychopathology. Dr. Good.
Well, thank you very much. It's a pleasure for me to be here. It's a little unusual for me to be here in the sense that I usually don't speak at IBS events. My area of interest is largely in issues of culture and psychopathology around the world, although I've been involved in for many, many years as a medical anthropologist, working first in a psychiatry department at the University of California, Davis, and now in a department of global health and social medicine at Harvard Medical School. Next, please. So what do we do with this? Okay. What I'd like to do today to begin this is to provide a kind of broad overview of issues from a point of view of medical anthropology that looks at the question that was raised about how symptoms mediate between culture and biology. And I'm going to take you through a kind of anthropological statement about the relationship between meaning and symptoms. That broadly argues that a certain kind of what I would call a standard medical hermeneutic about the relationship between the body and our expressions into words is often misleading and makes it difficult to do precisely the things that that was set as the target for this meeting, that is dealing with both international work but also cross-cultural clinical work. And I'll take on some of the kind of classic language that has developed within medical anthropology for dealing with such matters. Now, I would start out by saying something really quite simple, that there is typically within medicine, there is a view that symptoms simply reflect what's going on in the body. That if you have a pain someplace, it has a neurological basis to it, and that it gets expressed into words that reflect what's going on in the body. And I would say this general theoretical view is grounded in actually an older theory of the relationship between the order of words and the order of things, between the order of words and the order of the body, but that actually some of our current theories of how language reflects what is out in the world was actually developed by physicians. Some of our earliest understandings of language as naturalistic, as simply a more or less accurate reflection of how the world actually is, grew out of medicine. And it focuses on, as I say, representation and designation and a realist epistemology. That is, it says that ideally, words simply reflect the way the world is. And the more accurate language reflects what's out in the world, the more accurate our knowledge is, to the extent that we often make a distinction between somebody who has knowledge and somebody who has beliefs. And the very word, when we talk about other people having beliefs and us having knowledge, implies that our words accurately reflect the way the body is, the way some aspect of science, the way some aspect of the world is, whereas beliefs are somehow mistaken, essentially. That is, they may be culturally important, they may reflect cultural understandings, but they're essentially inaccurate. Over against this, anthropologists have been interested in language having a different form. That language actively constitutes forms of reality and forms of human reality. That there are rich understandings of the body, of medical knowledge, that are specific to high forms of traditional medicine, that are forms of what one might call alternative medicine, and that science itself is a cultural form, a distinctly cultural form, and that diverse forms of medical knowledge and medical practice are themselves rich cultural forms, and that those forms do not map in any quite neat way onto the body and bodily experience, but that the bodily experience emerges into a pre-existing world of language. In 1977 that Arthur Kleinman, Leon Eisenberg, and I wrote a piece in the Annals of Internal Medicine called Culture, Illness, and Care that continues to be referenced, almost embarrassingly, saying something about where this field has gone, but that made a distinction between disease and illness, and then talked about how disease is essentially how physicians think about and represent the body and medicine, and illness is an individual's and a community's experience of those conditions, and that very often people come with an interest in the treatment of illness and are dissatisfied with the care that they get because care is focused on disease, not on people's experience. I think that's particularly true in areas such as functional digestive issues, in which people come with hard to explain conditions in which the relationship between the words that people say to you and what you find explicitly physiologically don't map very well. And I put here the term hermeneutics. The term hermeneutics is essentially the science of interpretation. And my point is largely, as a kind of introduction to you, that the way anthropologists, medical anthropologists think about these issues is to say that the nature of interpretation, of how you get from, on the one hand, the symptoms that people describe to the body, and on the other hand, the symptoms that people have to the kinds of concerns that they have, is that the interpretation of those symptoms is not as straightforward as the kind of classic medical hermeneutics would imply, but it helps but requires an understanding of how people explain what their condition is, but also long traditions of experience, of attention to the body, of a rich somatic language that links up bodily experience, local, what I'll refer to as local biologies, as well as local systems of medical knowledge and healing. Now, just a word to say that biomedicine is one of many medicines. That it's, first of all, biomedicine is one of many formal classical forms of medicine. And as one goes around the world, so I've worked for years in Islamic countries. It turns out that Islamic countries in the Middle East, I've worked in Turkey and Iran. I work in Indonesia these days. Indonesia has a mix of Islamic healing forms and also old Hindu-Buddhist forms, that each of these have had high classic forms of medicine. That Islamic medicine really was a translation of Greek medicine, and that various local forms of healing are still related to the high traditions. In a place like China, where I also work, there are still high forms of the practice of Chinese medicine, and those actually make their way into how people interpret their body. That there are also religious forms of healing. And I would just say, parenthetically, that in our own society in the United States, we have a very rich alternative forms of medical practice that are around, through which people come to understand their body. As I was coming out from Boston on the airplane last night, I sat down beside a woman. I told her that I was going to a medical conference. She said she was going to one. She said, "What do you do?" I said, "I'm a medical anthropologist." And she said, "Oh, you'll love to hear. Talk to me for the next hour." And she is a specialist in environmental health, and launched into a description of how she herself had found that she has chemical sensitivities. Those chemical sensitivities she discovered while she's a physician. She was trained at Cornell. She's board certified in emergency medicine, but has become a strong advocate for environmental medicine. And just to give you a sense that what she gave to me says, "How is your environmental health? A doctor and a patient guide to identifying increasingly environmental illnesses. They include the big four: chemical sensitivity, chronic fatigue, fibromyalgia, GWS, and related conditions like autism, chronic Lyme, MS, autoimmunity, allergies, anxiety, and ADD." Now, to physicians, this starts sounding a little weird. On the other hand, I suspect that none of you would question that people live in very different environments, that those very different environments influence their guts and to their eating practices. And there is in America a very long tradition of food traditions, of now chelation therapies, of alternative therapies, et cetera. And anybody who is an American physician working in this area has to assume that patients who come to them will have read widely in these areas, will have ideas and explanatory models that grow out of these domains. And that people's experience and understanding of their bodies and their attempts to control and manage their symptoms and their understanding of and claims on physicians grows out of that kind of grows out of those kind of issues. And so that when Dr. Sperber mentioned the question put on the board, the issue of literacy, that literacy, of course, usually implies, do they know what doctors think? But literacy, of course, implies something much wider. Nowadays, given the internet, that literacy is even more complicated. And I put this up. This is from where I work in Yogyakarta, and it's a photo I'll show you a few times as the day goes on. But it is a reminder of bodily traditions that when you look at it immediately, it's very hard to interpret. That you have to know a lot to know what's going on in a high court dance like this, but also understandings of the body that go along with those. So let me just introduce a few terms in my remaining few minutes. First, the notion of local biologies. Often it is assumed that biology is universal, that differences that appear are essentially cultural. But one question really has to begin with to what extent there are local biologies. And I think that is, there are very different environmental conditions in which in which illness arises. There's a term ethnophysiology, that is, local understandings of physiology that shape how people understand and reflect on their body. And that suggests that symptoms are not simply reflections of bodily processes, but are mediators between the body, the person, and cultural forms. And so anthropologists use terms like idioms of distress to say that each society has idioms that are typically used in that society. Some of them are much more somatic than others. And the whole issue of distinguishing neatly between that which is somatic and that which is psychological often doesn't work very well. That people often use very rich somatic languages to discuss their affective experiences, their psychological experiences, and therefore the question of the relationship between somatic experience and psychological experience is not so clear. This is simply one little piece of data. It's an old one, but it came from a big cross-national sample that Alex Inglis, a sociologist, did, in which if you look at the top line, average symptoms per country, they weren't much different. They found not significant differences across them. But when you looked at what symptoms, these were broadly anxiety symptoms, but when you look the society by society at what symptoms were high and what symptoms were low, you found radical differences. That if you had taken, and methodologically for research, this complicates things, because had you left one of those symptoms out, you might have had very different average number of symptoms per country. So there is always a question of there being very different expression of symptoms across cultures that are related to the kinds of issues that I've been talking about and that have quite important implications for measurement. A word about somatization. It's a word that I suspect will appear now and again here, certainly if there are psychiatrists. And I want to just say a couple of words about, classically, the term somatization grew out of a form of psychiatric understanding that says essentially that somatization is the attention to somatic experience that is actually driven by psychological problems, but with a kind of denial or a failure to understand the psychological problems that underlie it. So it grew out of classic psychosomatic medicine and grew out of, I would say, a kind of classic distinction between those experiences of the body and those experiences of the mind. Arthur Kleinman was the first to really take this issue on in his work in China and to make an argument that somatization should be considered the cultural and psychological processes that amplify awareness of and concern for bodily symptoms. This then has gotten played out in acknowledging that the term somatization actually refers to a very complex, diverse set of phenomena, each of which needs to be measured independently and which varies independently, such as local vocabularies, idioms of distress, embodied and metaphoric ways of articulating the self and self-experience, bodily monitoring and catastrophic cognitions, which I'll have a chance to talk to you about later, personal meanings attached to particular symptoms, care-seeking patterns, presentation of symptoms, modes of communication in particular settings, and the evaluation of treatment and outcomes. And that an increased attention to the somatic over the psychological, as for example, may occur differentially in different areas. So for instance, people may express directly in medical settings an exclusive focus on somatic symptoms as opposed to psychological issues, but in other settings be perfectly willing to talk psychologically. People may actually have experiences of catastrophic cognitions associated with certain experiences. We focus in our society in particular on the heart and heart disease, but in other societies, other somatic symptoms are the focus of catastrophic cognitions